Hello, my name is Graham Chapman. I'm a fellow at University Hospitals and Metro Health Medical Center, and my presentation is titled Tamsulosin versus Placebo to Prevent Postoperative Urinary Retention in Women Undergoing Pelvic Reconstructive Surgery, a multi-center randomized controlled trial. We have no financial disclosures. The authors received grant support for this project from the AAGL Foundation grant in 2018. Of note, tamsulosin is not approved by the FDA for use in women. The FDA granted an investigational new drug exemption for this study. Postoperative urinary retention, or POUR, is the inability to adequately empty the bladder after surgery. Untreated postoperative retention can result in genitourinary damage, acute kidney injury, and urinary tract infection. Development of retention and treatment by catheterization has a significant negative impact on patient satisfaction, increases the risk of urinary tract infection, and elevates healthcare costs. The incidence of postoperative retention in female pelvic reconstructive surgery has been estimated to range between 21 to 50%. Risk factors have been identified in the literature, including high-grade cystocele, an anti-incontinence procedure, perineorrhaphy, higher surgical blood loss, as well as older patient age. Postoperative retention has a multifactorial etiology, including altered function of the detrusor muscle and bladder outlet due to the effects of medication, as well as anatomic, neuropathic, and inflammatory changes. Alpha receptor antagonists have proven effective in preventing postoperative retention in males undergoing pelvic surgery via inhibition of smooth muscle contraction in the bladder, neck, and urethra. Limited data in women exist undergoing pelvic surgery. Studies from 1983, 1985, and 1991 provided mixed results, all using phenoxybenzamine, which is an older non-selective alpha antagonist which is no longer commonly used. Newer selective alpha-1 antagonists such as tamsulosin specifically relax urethral tone and are effective in the treatment of lower urinary tract symptoms in women. The primary objective of this study was to determine if tamsulosin is effective in reducing the rate of postoperative urinary retention in females undergoing pelvic reconstructive surgery. We performed a multi-center, double-blind, randomized controlled trial. Patients were enrolled at Metro Health Medical Center and University Hospitals Cleveland Medical Center. We included all patients undergoing surgery for pelvic organ prolapse. We excluded those with a contraindication to tamsulosin, a history of urinary retention, and preoperative post-void residual of greater than 100 milliliters. Our study groups were randomized to receive either tamsulosin 0.4 milligrams or placebo capsules. For our intervention, study medication was started 3 days prior to surgery and continued through postoperative day 6. A standardized voiding trial was performed the morning after surgery. Questionnaires were administered at baseline and after surgery. The primary outcome was the development of postoperative urinary retention. This was defined as a post-void residual of greater than 100 cc's or greater than 50% of the voided volume, or the requirement of catheterization to facilitate bladder drainage. Secondary outcomes analyzed the impact of tamsulosin on the rate of postoperative UTI, as well as the American Urologic Association Symptom Index, or the AUA-SI, and quality of life scores. This is an example of the AUA-SI and quality of life questionnaire. This is an 8-item questionnaire regarding lower urinary tract symptoms and quality of life, with higher scores indicating more severe symptoms and worse quality of life. We performed a power analysis and determined that a total of 118 participants would be required to achieve a power of 80% with an alpha error of 0.05 in order to detect a decrease in the rate of retention from 30% down to 10%. To account for potential dropout rate of 15%, a total enrollment goal was set at 136 participants. We performed an intention to treat analysis for the primary outcome. We compared groups using chi-squared analysis and students' t-test for categorical and continuous parametric data, and Wilcoxon rank sum for non-parametric data. Logistic regression was used to control for confounding variables. This is our enrollment table. Of 390 eligible patients, 132 patients met inclusion criteria and agreed to participate. After exclusions, 118 were included in the intention to treat analysis. 11 participants were not completely compliant, leaving 107 in the per protocol analysis. This table looks at our baseline demographics and group characteristics. As can be seen highlighted in red, patients in the tamsulosin group had slightly lower BMIs compared to the placebo group at 26 compared to 29, with a p-value of 0.04. All other demographics and group characteristics were similar between groups. This table shows the preoperative AUA, SI, and quality of life scores. These were also similar between groups. As can be seen in bold, the total AUA-SI score for tamsulosin users was 14.2 compared to 14.5 in the placebo group. Quality of life scores were also similar. This table shows our surgical characteristics. In regards to operative time, estimated blood loss, and surgical procedures performed, there were no significant differences between groups. Of note, approximately 60% of patients received a concomitant midurethral sling, and this was similar between groups. Moving on to our outcomes. This table shows the univariate associations with the development of postoperative urinary retention. As can be seen highlighted in red, the preoperative total vaginal length was significantly associated with the development of postoperative urinary retention, with an odds ratio of 1.75 and a p-value of 0.04. All other factors were not associated significantly with postoperative urinary retention, including but not limited to age, preoperative PVR, BMI, prolapse stage, other POP-Q values, operative time, surgeon, midurethral sling, and other prolapse procedures performed. This table shows the associations of the preoperative AUA, SI, and quality of life scores with the development of postoperative urinary retention. As can be seen highlighted in red, both the severity of urinary urgency as well as the total AUA, SI scores in the preoperative period were associated with the development of urinary retention. For both of these items, a more severe score indicated a lower risk of urinary retention. Onto our primary outcome, the association of tamsulosin use with postoperative urinary retention. Tamsulosin users experienced a significantly lower rate of urinary retention at 8.7% compared to 24.6%. This carried an odds ratio of 0.29 with a p-value of 0.027. Multivariate logistic regression was then used to control for potential confounders, including BMI, total vaginal length, and the AUA-SI score. Tamsulosin use remained the only significant predictor of postoperative retention with an adjusted odds ratio of 0.14 and a p-value of 0.018. All other factors in the regression carried a p-value of greater than 0.05. We then moved on to our secondary outcomes, analyzing the impacts of surgery and tamsulosin use on the AUA, SI, and quality of life scores. This figure shows the change in AUA, SI scores before and after surgery. On the left, you can see the baseline preoperative AUA, SI scores with a normal distribution and a median score of 14. On the right, you can see the postoperative AUA, SI scores with a significantly higher number of patients reporting lower scores and a median of 7. This table shows the perioperative improvement in the AUA, SI, and quality of life scores in tamsulosin users versus placebo users. In the second column, we see the median improvement in the tamsulosin group, and in the third column we see the median improvement in the placebo group. As you can see highlighted in red, patients using tamsulosin had a higher improvement in the symptom of weak stream with a median improvement of 1 point in a range of 0 to 3, compared to median improvement in the placebo group of 0 with a range of 0 to 1. This carried a p-value of 0.04. The mean improvement in the total AUA-SI score was 7.3 in the tamsulosin group compared to 5.1 in the placebo group. This carried a p-value of 0.21. So in this prospective randomized trial, tamsulosin use was associated with a reduced risk of postoperative urinary retention in females undergoing pelvic reconstructive surgery. Rates of urinary tract infection were similar between groups. Tamsulosin use was associated with subjective improvement in urinary stream, although most lower urinary tract symptoms did not differ between groups. Study strengths include that this was a prospective randomized design, we had well-matched study to groups, and our use of placebo to minimize bias, as well as our multi-center enrollment. Limitations include the enrollment was limited to academic medical centers, potentially limiting the generalizability to the general population, as well as that the study was underpowered to compare the effects of tamsulosin on postoperative urinary retention in smaller, more specific subpopulations, such as those who underwent concomitant. In conclusion, the results of this study support the use of tamsulosin to prevent postoperative urinary retention in women undergoing female pelvic reconstructive surgery. Future studies may consider the use of alpha antagonists to prevent postoperative urinary retention in high-risk subpopulations, such as those with a history of incomplete bladder emptying, as well as those undergoing isolated surgery for urinary incontinence. These are my references. Thank you for listening.